Welcome to this presentation on the A to G patient assessment. This is part of Westmead Private Hospital's initiative in ensuring that we provide the necessary tools for our clinicians to be able to make quick assessment and judgment in the event that a patient is deteriorating. So, the overview of this presentation is to outline the A to G assessment and some associated interventions that nurses and midwives could initiate prior to a clinical review or prior to the doctor arriving on scene. We will also provide an example of documentation that a nurse or midwife could write in the event that they had to do an A to G assessment for a clinical review. So, first things first, the A to G assessment is a quick, structured survey that helps to assess patient care priorities. It's a very useful tool when detecting deterioration, and it relies on the assessment skills of inspection, palpation, and auscultation. First letter stands for the airway. Here, we would first assess whether or not the airway is patent and obstructed. If patent, we would then proceed to observing the next letters. If obstructed, of course, we would need to intervene and consider doing the following: either suctioning the secretions, using jaw thrust or chin lift, and of course, calling for assistance. The next step is breathing. Here, we would evaluate more than just the respiration rate that we've done during our vital sign assessment. It includes the work of breathing of the patient. Is it effortless, or are they using accessory muscles? What about the breath sounds? When we auscultate, we can use our stethoscope to do a quick assessment on whether or not we can hear any abnormal breathing sounds, which include wheezing or crackles, for example. Here we would also review any oxygen requirements and look at their current position and maybe help them in a position that is appropriate for their breathing. And we would also be looking at their color. So this is a quick chart or image rather of the areas by which we can auscultate. You can see that if a patient is able to lean forward, you can hear breath sounds better at the posterior side rather the anterior side. Worthwhile to do. Again, if there is an alteration to breathing, it is important for us to initiate some nursing interventions to be able to assist. This includes, but it is not limited to, patient positioning, applying oxygen during the immediate period. But please remember that increasing oxygen requirements will require clinical review. There is something that's wrong in the patient when we keep applying more and more and more oxygen. So they really need a review. And also providing reassurance and appropriate levels of communication with the patient. The next letter is circulation. Here we're already checking blood pressure, the heart rate, the pulses, capillary refill, and temperature. If you're concerned, it's always good to not only rely on an automated blood pressure reading, but also on a manual blood pressure reading. What about the person's heart rate? Not just looking at the machine, but actually also feeling the pulses and observing and assessing the characteristics of the pulses. Looking at cap refill, a normal one, of course, is less than 2 seconds, and also feeling the patient's temperature. Again, not only just by machine, but how does the patient actually feel? So some interventions that you could do in regards to circulation in the interim period while there is a review that needs to be done, patient positioning, consider conducting an ECG should the heart rate be altered too high or too low, and of course, your reassurance and appropriate therapeutic communication are important interventions to take whilst you're assessing and providing interventions. For disability, here you're assessing for level of consciousness. If they're on any opioids, you're assessing how sedated they are. And if they're immediate post-op, it would be worthwhile to also assess the presence of nausea and vomiting. Here we are using, for a quick scale of level of consciousness, it would be the ALF-POO scale: alert, verbal stimuli, painful stimuli, or unresponsive. These are located, this assessment tool is located in your vital sign chart. And if there's any alterations to this, whereby the patient is responding to painful stimuli or obviously unresponsive, you would initiate appropriate help. So, again, if there's an alteration in disability, initiate the appropriate interventions. This includes, but is not limited to, keeping the patient safe. If you note an altered level of consciousness, it's also good to check a BGL. So, blood glucose level, not only for diabetics, but for anyone you're concerned of a potential alteration in their level of consciousness. Here, it's important to call for help and make sure you get a clinical review, if not a rapid response review, depending on the assessment results you have. E stands for exposure. Oftentimes, in the heat of the moment, we forget to have a good look at everything the patient presents to us, particularly on the wounds that are hidden behind the sheets. So, looking at the wounds, can you note if there's a hematoma occurring? Are they bleeding internally? Or looking at the drains, are they bleeding more than usually? It's also useful to check the intravenous cannula because sometimes it could be a source of infection as well. So looking at the patency of the cannula and any phlebitis or infection is important. If there is an alteration in exposure, it is important to initiate nursing interventions to assist. Again, this includes, but is not limited to, patient positioning. If they're bleeding, how can we minimize gravity causing too much bleeding? Applying compression if applicable and if able. Of course, reassurance and again, appropriate therapeutic communication and calling for assistance or help. The next letter relates to fluids. If we're particularly worried about instances of hypovolemia or hypervolemia or any alterations with fluids, or a fluid shift for that matter, it's important for nurses and midwives to also check what has been the input of the patient as well as the output, with particular emphasis on urine output. We're particularly worried about the kidneys, how they are operating in terms of urine output. So it's always good to check. If there are any alterations here, you can look into considering what appropriate patient positioning. If they have urinary retention, doing a bladder scan is appropriate. And of course, always your reassurance and appropriate therapeutic communication. Lastly, I mentioned this earlier in regards to altered level of consciousness. Doing a glucose check is very useful, but also considering in your patient assessment, if you have the notes on hand, what's going on with the other pathology tests. For example, what is the HB of the patient? What are the electrolytes of the patient? That will help give you a better overview of what's going on. So here's an example of documentation of an A to G assessment. This is just an example of what I've written here. You've got the date and time, you've got nursing there, and the patient presented with a heart rate of 130. You've initiated a clinical review. Patient with patent airway and breathing spontaneously, respirate 18, SATs 98% in room air, bilateral air entry noted, ECG done and awaiting review by ward CMO, BP 105 on 85, pulses are thready, cap refill less than 2 seconds, temperature 37.0. Patient alert and orientated with complaint of pain to surgical site with score of 4 out of 10. Nil nausea noted but stated feeling dizzy. Surgical site dressing is dry and intact. IVC to left hand patent and in situ with nil phlebitis. Sodium chloride 0.9%. Infusion continues at 100 mils per hour. Patient has passed urine in toilet this shift. Patient currently positioned in semi-Fowler's position. So here is just a quick way of writing what you've done while you're waiting for a clinical review to be done or completed by the ward doctor. Here it just gives you an ability to demonstrate the assessments that you've done during the need or for the need to call for assistance. So thank you for listening. If you have any other questions, please approach your department educator. Thank you.